Let's start with the basics today. Welcome to another session of Bear for Health podcast. Today we are talking about a very common rhythm disorder, that is atrial fibrillation. So let's start with the basics, that what exactly is atrial fibrillation?
Atrial fibrillation is one of the most dreaded morbidities for people who are growing or elderly because it results into the incidence of a stroke, which is almost 5 times higher than a person who has a sinus rhythm. Now, what is all this rhythm all about? I'll just explain you. The small chambers of the heart, which we call as atrium, when they start quivering or fibrillating, as in they are not contracting like the heartbeat, they start fibrillating and contracting at a very high rate of 200 plus or 250 plus, meaning thereby they are almost ineffective in contracting, and there is a stasis of blood in the chambers in the atria. Now, this stasis or stagnation of blood would lead to formation of clot in the atrium, especially left atrium, and then these clots would travel to your brain, resulting into very fatal strokes. So this is all atrial fibrillation is all about. Unfortunately, there are no symptoms of atrial fibrillation except for a little palpitation, which is very subtle, and some of the patient can just pass it off as a routine thing, which happens with a fast heartbeat. But if you actually notice it on your smartwatch or on a Holter recording, 24 hours ECG recording, you would find to your surprise that your atrium are actually fibrillating and your heartbeat has become irregular. So an intelligent patient would come to appreciate that his heartbeat is fast and irregular, and that is a sign that he has to take precautions to prevent a stroke happening because of this atrial fibrillation.
So there are so many patients who are taking blood thinners regularly and lifelong, probably to prevent a stroke from such a rhythm disorder. So what all should they know? When should these patients get worried? What are the risks of these medications? So what all should they know about it?
So coming back to your first question, which unfortunately I missed, that how would you decide that patient should be put on anticoagulation or not? So when we see a patient of atrial fibrillation, we go through the whole profile of these patients, as in these patients, what is their age, what is their gender, what is their underlying status of diabetes or blood pressure or heart failure. Given these risk factors, we make them points and we sum these points up. Whenever these points, or what we call the Shatz-Bask score, exceeds 2 in women or 3 in man and 3 in women, these are the patients who are more a propensity to have strokes, clot formation, and they should be by rule put on some kind of anticoagulation and on a regular basis. Once started, these anticoagulation should be given for life because the risk of stroke remains forever if a person has underlying atrial fibrillation.
So, apart from these medications, are there any other strategies to deal with the atrial fibrillation? Many times, patients are elderly and they may not be able to tolerate such anticoagulant therapy, and there's always a risk of bleeding in them. So, what are the other treatment options for such patients?
Right. So that's a very good question. The prevention of stroke and clotting comes with the inherent risk of excessive bleeding if these patients are taking anticoagulation. But the benefits of taking anticoagulation preventing a stroke are far higher and far more than inviting bleeding because of this. Yet there are a few patients who have propensity or vulnerability for bleeding, and these patients somehow cannot tolerate anticoagulation because they could lead to catastrophic bleeding in the brain or in the gut or in the stool. And these patients are virtually intolerant to the anticoagulation. In such patients, we try to block certain areas of left atrium which act as nidus for clot formation. That is called as left atrial appendage. There's a finger-like structure which is attached to the left atrium, part of the left atrial cavity. That is the place where most of the clots would form. And so by interventional techniques, we would like to block those appendages called as left atrial appendage occlusion. And that's a very simple process done through the groin. The plug is left there to block it, and therefore no clot would form in the sinus in spite of having underlying AF. And one can do away with anticoagulation in such situations where the bleeding risk is high or patients are not tolerating anticoagulation, as in the patients who have underlying cancer or any bleeding propensity because of other comorbidities. So that is another way, alternate way of preventing stroke in atrial fibrillation patient. But I must emphasize here that detection of AF is very, very important, because sometimes AF would present as the first symptom as the stroke. And to your horror, you would realize that patient has already suffered paralysis. And you realize now that the patient was actually suffering from underlying atrial fibrillation, which he ignored, or he could not diagnose because he had no symptoms or very subtle symptoms. So it is very important to pick up atrial fibrillation by various diagnostic modalities, as if giving them a Holter or a 7 days ELR, extended loop recorder, or even your smartwatch. If it is connected to your heart, it can give you ample information that at what points are you having atrial fibrillation and when is your rhythm sinus. So detection of AF in itself is a big challenge, and there's a lot of emphasis globally to diagnose AF so that we can take preemptive and preventive steps in time.
So, apart from the medications, a lot of these patients are having other comorbidities like diabetes, hypertension, and multiple issues. So, how important is it to control the other issues apart from dealing with the atrial fibrillation?
So as I said, the task in management of AF is first is control of rate versus rhythm, bringing it back to regular sinus rhythm. Number two, prevention of stroke. And number three, which is very important, the lifestyle management. And in which, apart from controlling these risk factors, which I cited, like blood pressure, diabetes, heart failure, advanced age or gender, one has to look at the history of smoking. One has to quit smoking, history of excessive alcoholism, because that can also predispose to AF and clot formation. Weight control, especially if patient happens to be diabetic. Strict sugar control is very important. Control of renal parameters. And these are some of the lifestyle changes which has to accrue if you're suffering from atrial fibrillation. So these strategies would go in tandem along with drug. The lifestyle changes have to go on.
So, my last and final question is that what is your advice to somebody who has been diagnosed with atrial fibrillation but feels fine, is asymptomatic, and still should this patient still be worried about getting a stroke? And what are the current guidelines on such patients?
So any episode of atrial fibrillation which lasts more than 24 hours would qualify to be called as a permanent AF or a prolonged AF, compared to paroxysmal AF, which would just last for a few minutes or hours, maybe 6 and 8 hours. Now there could be distinction. Patients who have transient episodes of AF lasting for more than less than 24 hours could be managed with a simple aspirin, especially if their Shatz-Wasser score are low. But those patients who have AF episodes lasting for more than 24 hours should, by rule, be put on some kind of anticoagulation to prevent stroke. And if you're not doing it, failing to do that, you're inviting the risk of stroke and catastrophic stroke in these elderly patients. And eventually they would become handicapped and dependent on family members. So they become a liability. So it is very, very important to diagnose AF by the methods which I've cited, by putting in a Holter or an ELR or a smartwatch. Once diagnosed, you must put these patients of anticoagulation. The NOACs like rivaroxaban is a wonderful NOAC which just needs to be given once in a day in 24 hours, keeping a close watch on bleeding risk. And if that happens, if patients are intolerant to anticoagulation, one could always opt for the left atrial appendage occlusion devices, which are done by us as interventional fraternity.
So, this is an
Yeah.
extremely common rhythm disorder, atrial fibrillation, and it is very prevalent in the society. So, I think everybody should be knowing about this disorder, how to prevent it, how to control it, and about the lifestyle modifications required for this. Thank you very much.
Thank you, Dr. Vasavdatta. Thank you.